Data from the World Health Organization shows the global prevalence of mental disorders. Right now, roughly 970 million people live with a mental health disorder. The bulk of this burden is driven by anxiety at 31% and depressive disorders at nearly 29%. Despite these enormous numbers, there is a clinical paradox. Patients in primary care rarely present with a textbook chief complaint of anxiety or depression. Instead, they present with medically unexplained somatic symptoms. A patient will book an appointment for persistent gastrointestinal distress, severe headaches, insomnia, or unyielding musculoskeletal pain, masking the underlying psychological etiology. Because these multiple vague physical symptoms obscure the true cause, providers often pursue exhaustive and unnecessary medical workups, leading directly to misdiagnoses. When a psychological issue is suspected, the triage model relies on referring to a psychiatric specialist. That system is failing. There is a severe psychiatrist shortage, and siloed care creates impossible bottlenecks. With specialists overwhelmed and psychological distress manifesting as physical pain, primary care providers are now the de facto frontline of the global mental health crisis. Treating these millions of patients requires an entirely new operational workflow inside the primary care clinic. The structural solution to this psychiatric bottleneck is the collaborative care model. This system integrates behavioral health directly into the daily primary care workflow. This diagram maps the new ecosystem. At the center is the patient, supported by the medical provider and a behavioral health care manager. The care manager acts as the operational bridge, usually a clinical social worker. They provide brief counseling, track treatment adherence, and collect clinical outcome metrics. They also maintain a shared registry connected to a consulting psychiatrist. This provides asynchronous oversight and prioritizes complex cases without requiring patients to wait months for an appointment. Keeping patients anchored within the primary care ecosystem they already trust reduces care fragmentation. It destigmatizes treating behavioral disorders and drastically reduces the time it takes to initiate therapy. Structural integration pulls mental health care out of an outsourced specialty silo and turns it into a highly efficient in-house primary care capability. At the level of the individual clinical encounter, providers need a reliable way to sort through vague, multiple somatic symptoms and identify the underlying pathology. This is the Generalized Anxiety Disorders 7-Item Scale, or GAD-7. It is the primary screening instrument deployed the moment an anxiety or depressive disorder is suspected. Notice that severity is dictated by frequency. The scoring columns weigh symptoms occurring over half the days, or nearly every day. A total score of 10 or greater is the threshold that triggers active clinical decision support. A high score must be contextualized because fear and stress are normal parts of human life. To identify pathological anxiety, 3 rules apply. The anxiety must be out of proportion to the situation, it must persist beyond the precipitating stressor, and it must cause concrete impairment in social or occupational functioning. Providers must also rule out physical mimics. This requires excluding cardiac, pulmonary, or endocrine etiologies, such as ordering a routine TSH lab, and ruling out substance-induced anxiety caused by caffeine, illicit stimulants, or steroids. When evaluating for depression, providers must distinguish clinical pathology from normal bereavement. True major depression involves profound feelings of worthlessness and self-loathing. In normal grief, a person's self-esteem is usually preserved, even amidst intense sadness. Analytical. This flow sheet visualizes the required differential diagnosis process. The second block explicitly mandates checking for comorbid medical conditions and medication or drug-induced symptoms before confirming a specific anxiety disorder. This rigorous differential diagnosis isolates the true pathological signal. It prevents the overtreatment of normal human stress while ensuring that severe mood disorders are not fatally undertreated. Once a pathological disorder is confirmed, treatment follows a strict measurement-based escalation protocol known as stepped care. This chart breaks down the 3 distinct tiers of intervention. Step 1 addresses mild symptoms. Providers initiate accessible, low-cost lifestyle interventions like physical exercise or mindfulness. If a temporary stressor is identified, a period of watchful waiting is appropriate. For moderate or persistent symptoms, we move to Step 2. This requires escalating care to either cognitive behavioral therapy or pharmacotherapy. Both CBT and pharmacotherapy are considered equal first-line options. They each offer roughly a 50 to 60% response rate. Because their efficacy is comparable, the initial choice between them is driven entirely by patient preference. Cognitive behavioral therapy is a short-term, goal-oriented process. It is designed to execute cognitive restructuring, replace avoidant behaviors with direct exposure therapy, and reduce overall levels of autonomic arousal. By following the stepped care algorithm, primary care providers have a predictable roadmap. It prevents premature medicalization for mild stress, while guaranteeing a clear, aggressive path for escalation when initial interventions fail. When a patient at Step 2 elects for medication, prescribing follows rigid pharmacological rules of engagement. Selective serotonin reuptake inhibitors, SSRIs, and SNRIs are the absolute first-line agents. They possess a superior safety profile and offer dual efficacy in treating comorbid depression. Anxiety patients are uniquely sensitive to medication side effects. Providers must start at the lowest possible dose and titrate up slowly. Significant symptom relief takes time, requiring patience before evaluating true efficacy. If the initial SSRI yields an inadequate response, we move to Step 3. For partial efficacy, augment with CBT. If completely ineffective, switch to a different SSRI or SNRI and actively screen the patient for occult substance use or undiagnosed bipolar disorder. The slow neurochemical stabilization of an SSRI contrasts sharply with second-line agents like benzodiazepines. Benzodiazepines cause sedation, impair cognition, and create rapid low-dose dependency, especially short-acting agents like alprazolam. Most importantly, they offer zero long-term outcome improvements. The use case for benzodiazepines is extremely narrow. They are restricted to short-term bridging for severe symptoms and only in patients with absolutely no history of substance or alcohol abuse. Pharmacological success requires clinical discipline. Providers must resist the urge for a quick, dangerous benzodiazepine fix, prioritizing the slow, sustainable relief of an SSRI. In modern primary care, achieving psychiatric remission is not based on subjective clinical intuition. It is driven by hard, objective data. In the collaborative care ecosystem, the behavioral health care manager re-administers the GAD-7 at every follow-up. This data feeds the central registry, acting as an active monitor to trigger treatment step-ups or psychiatric reviews, ensuring no patient languishes on ineffective therapy. Once an effective therapeutic dose is reached and symptoms are relieved, the endgame requires patience. The provider maintains that exact treatment for 9 to 12 months before considering a slow taper. Standardizing collaborative care, GAD-7 filtering, and stepped care allows primary care clinics to manage complex psychiatric cases with the same precision as chronic physical diseases. Operationalizing these clinical blueprints establishes primary care as the definitive arena for treating and resolving the global